Are you ready for this? It's chapter 12. We're at week 12. And this week, it's all about clinical epidemiology. You're probably wondering why I don't have some kind of joke or meme or something like that. Actually, I think this in itself is quite an epidemiological joke. It's rather amusing. And we'll talk about this at the end, but it's entitled Everything We Eat Both Causes and Prevents Cancer. All right, so here we are, you guys. This is week 12, of course. We're finishing up Unit 4 today. Next week is the week of our Thanksgiving holiday, of course. Now, the lecture today is not long, but you have a couple of, well, one's an official assignment where there's a rubric, and the other one is a TED Talk that I want you to listen to. Like I said, it's a short lecture today. It's more you doing stuff. That way we can get everything done, and that way you'll be free for Thanksgiving week, except for the exam. You still have to complete the exam for Unit 4, but hey, it's going to be kind of short, isn't it? There's only 2 chapters, right? 11 and 12? Woohoo! And all right, that gives you a little flexibility also to work on your video project, because the following week the video project is due before Wednesday, November 28th at 11:59 p.m. Now, with that, there is a student discussion, and that is due before Sunday, December 2nd at 11:59 p.m. You're probably wondering, does that mean everyone will see my video? Yeah, that means that the class will be viewing your video. Keep that in mind. This is really the only thing that we're doing that week. And I'm doing this because I want to make sure that you are all done with your coursework in time for graduation, in case anyone is graduating. And occasionally people are graduating after my class. And last semester, some people, we were still waiting on grades, and I'm not going to have that happen again. So you'll be done right on time. In fact, maybe a little early, a smidgen early, okay? All right. Now, for the assignment this week, this has to do with screening tests. And because this is clinical epidemiology, we're going to be talking about screening and diagnoses. And of course, there are many tests out there that people take, right, to get screened for certain diseases. So you are to find one screening test commonly used here in the United States. Now, the screening test that you come up with has to be original. It can't be a test that was already taken by another student. So get yours in early so you can pick and choose. Nor can you use breast or prostate cancer tests, because I'm pretty much already covering those in some detail or to some extent. And so then just tell us all about this test, okay? Of course, that has to be in by 11:59 p.m. on Friday. What's the follow-up? Second post? Well, glad you asked. Rather short, just 50 words, but you need to read and respond to someone else's post. So you need to look at their screening test, okay? And describe what you find most interesting and why. Then you need to go and research that person's screening test and try to find, try to find the rate of false positives. Yes, some tests give you false positives. And yes, that could produce some anxiety. So find some literature. Don't forget to cite these in APA. Your first post must have at least two reputable sources cited in APA. And your second post should have at least one reputable source cited in APA. Okay? And if you have any questions or problems, just email me. Hopefully you don't find some really bizarre test that doesn't have a whole lot of information associated with it, but it should have sensitivity and specificity listed, and most of this information should be there, okay? All right, so maybe listen to the lecture before doing the assignment, right? Okay, and here's the rubric. It's just like last time. Okay, here are the chapter objectives. Define clinical epidemiology. Discuss various aspects of screening and diagnostic tests. Describe various measures for evaluating prognosis. Evaluate potential biases and ways to avoid bias in evaluation of tests and treatments. And the terms list is, well, rather short, but hey, you have already learned a lot of terms in epidemiology already. So, yay, that's pretty short and sweet. Well, the first objective has us identifying and describing clinical epidemiology. So, well, what is this? Well, this is the specialty area in epidemiology that involves the application of epidemiology to screening, diagnostics, diagnosis, prognosis, and treatment. Okay? So, clinical epidemiology focuses on patients and the application of epidemiologic methods to then assess the efficacy of screening, diagnosis, and treatment in the clinical setting. So, how well are they working or not? It's also used to identify the health consequences of employing a test or administering a treatment. Is it going to improve the outcome or not? All right. And really, this all focuses on secondary prevention, if you remember that. So, health screening and detection activities used to identify disease is considered secondary prevention. Okay? Okay, so screening and diagnosis, what is the difference? Well, first of all, screening tests are there to detect early disease or risk factors in large numbers of apparently healthy people, okay? Healthy individuals. Basically, you're out there, you're looking for trouble, okay? Now, diagnostic tests are a little different. You diagnose what is wrong with people who already have the symptoms. And diagnostic tests are used to confirm disease. Usually these are a little more expensive, sometimes a little more invasive, okay? All right. So, screening. When is screening appropriate, right? Well, you really want to try to catch the time right before the biological onset of disease. That's the best time to do that if you're going to screen, and you want to hit it before they would have normally have had clinical diagnosis. So screening, the purpose is to identify disease or risk factors in the asymptomatic individuals before signs and symptoms hit. So this is the progression of the disease. We start with biological onset, and here we have some breast cancer cells. Now this is way too big. Usually the onset or the biological onset would just be a single cell, right? Okay, and one cell would divide to become two become four, but it takes a little while before you would notice that. And eventually, if this continued, you get a lump, maybe it would spread to a lymph node, you'd have lumps there, and then you would seek clinical help, right? And you would probably get a clinical diagnosis. Well, this is too late. So screening is actually designed to catch you right about here before you would actually go in for clinical diagnosis. So really it's looking for asymptomatic individuals before signs and symptoms. Make sense? Okay, and hopefully this is going to change the outcome. Okay, so screening can accelerate the time of diagnosis. True or false? Well, yeah, yes, absolutely. You get screened, you're positive, you go in and get a diagnosis. So, absolutely. Okay, so what are the screening guidelines in clinical epidemiology? So, if you want to do a national screening test, you want to set up a screening program, what are the screening prerequisites that you should have? Well, number one, the disease should be a major health problem because you're going to focus a lot of resources into this. If it's not a big problem, then sorry, you have to probably funnel all this money and these resources into screening for something that is more common. The screening test should identify the disease before clinical symptoms or diagnosis. Well, again, yes, if your screening test can't catch you before clinical diagnosis, well, then it's really not any good, is it? Early intervention should lead to better outcomes. So you should be by perhaps adding chemotherapy or something else, you should be able to change the outcome. If screening doesn't provide, and if screening and early intervention doesn't lead to better outcomes, then okay, why waste resources on a test that tells you that really there was nothing you can do about it anyway? Everybody was just going to show up for clinical diagnosis, and early screening really wasn't going to make a difference. Okay, what else? The treatment should be acceptable. It should be, available for individuals with diseases discovered in the screening process. Okay. And patients should have access to healthcare facilities and services for follow-up diagnosis and treatment for the discovered disease. Okay, all of that should be available. I mean, okay, yes, we found out you have cancer. Bye-bye, good luck. Yeah, that's bad. The disease should have a recognizable course with identifiable early and late stages. So you should know, okay, early stages, maybe a lump here or a mass here, versus late stages that have spread and metastasized everywhere. Okay. All right. Policies and procedures and threshold levels on tests should be determined in advance to establish who should be referred to further testing, diagnostics, and possible treatment. That all has to be in place. The process should be simple enough to encourage large groups of persons to participate. If this is miserable and wretched, then okay, that's not very good. Unfortunately, prostate examinations are considered not very simple, but it's the best we can do. And it would be nice to have something that is a little more well, I hate to use the word appealing, but appealing to the male population. What screening tests do we have for cancer, you ask? I'm so glad you asked. Here are some examples. The first one we've talked about. First of all, there's the Pap test, like a Pap smear. Of course, the cervix gets scraped, and the histological samples are sent to the laboratory. What does that mean? That means that the epithelial cells, the cells that make up the cervix, are scraped off, put on a slide, and they are stained and looked at by a histologist. And this individual would see some epithelial cells that do not look normal. Okay? So, of course, that would look for cervical cancer. Yes. Mammograms, yes, screening for breast cancer. It's a little bit of a squishy test, but hey, no one has ever died from the test. So you just kind of suck it up, ladies, if you've never enjoyed it before. Yeah, it's coming, but it's okay. Treat yourself to chocolate afterwards. Okay, then there are blood tests, such as the PSA test. The PSA stands for prostate-specific antigen. So you have to look in the blood, and we will talk about the PSA test a little bit later on, but it's looking to see if this gentleman possibly has prostate cancer. Yes, you can look in the blood. And then there's fecal occult blood tests. It looks a little something like this. And if there is blood in the feces, then it will show up here, and that could be an indicator for colon cancer. And then also, you can take a small blood sample to look for leukemia. Of course, this is a cartoon representative of what leukemia might look like. This would be normal blood cells. You'd have Oh, a few white blood cells, but mostly red blood cells and a few platelets. If you have leukemia, you have a tremendously high number of white blood cells. Okay? And certain kinds, by the way, usually the lymphocytes. Okay. What are some other common screening tests not associated with cancer? Well, of course, there's blood pressure determination, cholesterol level determination. There's eye exams, urine analysis, tuberculin skin tests, and something called the Beck Depression Inventory. It doesn't look like this, and I don't know if you've ever taken this before. But just a little background, the original Beck Depression Inventory was a screening test that was, it was published in 1961. It's a psychology test, and it consists of about 21, well, excuse me, it does consist of 21 questions inquiring how a person is feeling. And you would be rated on a scale of 0 to 3. From I don't feel sad to I am so sad I can't stand it anymore. 0 is I don't feel sad. 1 is I feel sad. 2 is I am sad all the time and I can't snap out of it. And 3 is when you've got the I'm so sad or unhappy, I can't stand it. And the higher your score at the end of the 21 questionnaire, that would indicate depression. So a high number is severe depressive symptoms, okay? All right. Okay, so then there's two things to talk about: mass screening compared to selective screening. What's the difference? Well, if you've gone to a health fair, that's a mass screening. It's not selective, but it involves application of screening tests to the total population. So big health fairs, okay? As opposed to selective screening, and that involves applying the screening test to high-risk groups. So, for example, that would be your tuberculin test, like this one. If you are working with patients, right, then you need to have your tuberculin test regularly. Okay, more on that later on. Okay, how about a question? Selective screening refers to screening tests performed on high-risk groups. True or false? It's selective. Yes, you're only going to do that on high-risk groups, so true. All right, so these screening guidelines, I mean, are they any good? How do we evaluate screening? Okay, good question. So how can the application of epidemiology provide a means for evaluating screening guidelines? Well, epidemiology will supply the descriptive and analytic epidemiologic methods, and they're very useful for establishing and understanding screening and its effectiveness. Okay. All right, so it will look at the extent of the public health problem, the efficacy of treatment, the access to health care, the natural course of the disease, and the efficacy of a screening or diagnostic test. So all of these things we've been learning, yes, this can be applied to screening and screening guidelines. Okay? All right, so on that note, all right, what about validity? I can say that. Validity, reliability, and yield of the screening test. Okay, is it any good? All right, well, okay, based on epidemiologic studies, we have some data on that. All right, so what is validity? That means how well the test actually measures what it's supposed to measure. Okay, that's good. It's valid. It's not valid. Okay, reliability. This is how well the test performs in use over time. Is it repeatable? And, can you rely on it? Okay, that makes sense. Yield is the amount of screening the test can accomplish in a short period of time. If this is a very complex, drawn-out test, and you really can't screen very many people effectively, then okay, that's not very good. But if you can screen a whole bunch of people, like with health fairs, and take their blood pressure and do some blood tests, okay, we can do that. In a little more detail, validity, again, it refers to the accuracy and trustworthiness of your instruments, your data, and findings in research. And here, of course, we have a glucose meter, right? And you hope that the instruments that were used were, used to measure, they're measuring something valid. You would hope so. And you may not be familiar with a glucose meter, but you might be familiar with, I don't know, tests that are there to assess your learning and how much, how much you have grasped in your years of education, and also to determine where you should be placed in higher education. Of course, this is the GRE, the SAT, and the ACT. What is the validity of those tests? Well, I'll tell you, it's a little, sometimes it is, sometimes it isn't, but it's the best test we have for the most part, or the best tests. Okay, moving on to accuracy. Now, this is the degree to which the measurement represents what it is intended to represent, okay? And accuracy has a very important influence on validity. So do you find that 3 generic glucose strips, for example, used all at the same time gives you 3 different readings? Okay, now that might seem silly, but I was just talking to a friend who has type 2 diabetes. She's recently diagnosed, and because she's on a fixed income, she really is having trouble paying for glucose test strips. Okay, so she sent away and went online and got some very cheap generic glucose test strips. Well, she has a scientific mind, and she wanted to test several strips to see if they had accuracy. So she did 3 tests in a row, and the glucose level in her bloodstream shouldn't have changed, but the reading sure did. And so basically she threw out the glucose test strips. Yeah. Okay, how about a question? I know, isn't that sad? All right, what refers to how well a test measures what it is designed to measure? I mean, can you trust the test? Validity, reliability, efficaciousness, or effectiveness? Of course, that's validity. Okay? How well a test measurement reflects the test validity. That's accuracy, reliability, efficaciousness, or effectiveness. That would be B, reliability. Very good. Okay, so more about measurements of validity, because that's really important. How do we know to trust some of these tests, right? Okay, well, first of all, we have some terms. If we have a test, we want to know its sensitivity. This is the ability to test, the ability of the test to correctly identify those with the disease and detect a true positive. And therefore, it picks up any possible indication of disease. So, okay, and if you're wondering what this lady has, this is known as EpiCh for HIV, okay? Just so you know, it has a sensitivity of about 93%, okay? Now, there's also specificity. Now, this is the ability of the test to correctly identify those without the disease. Really, only a very specific indicator or concentration of indicators will be picked up then by a very, very, very specific test. So, okay, back to the EpiCh, its specificity is 99%. Okay, as you could imagine, the higher the percentage, the better it is. It would be nice to have a number that's higher than 95%. But sometimes that's a little hard to do. And if you're wondering, this little rapid HIV 1 and 2 antibody test just looks at oral fluid collected from participants. Okay? All right. Now, you also want to know overall accuracy, and this is the ability of a test to predict the presence or absence of disease. So that's kind of like everything. It includes sensitivity and specificity. Okay, how about a question? The ability of a test to determine true positives is its Validity, reliability, sensitivity, specificity. What do you think? Okay, well, we're looking for sensitivity. Okay, that would be our C. More on that coming up. So what is up with these false positives and false negative results? Well, they most always appear in screening tests, just so you know. All right, so what's the difference? A false positive. The person doesn't have the condition or disease, but the test suggests that they do. Now, this will lead probably to more tests. There's an emotional cost to this. I can say this firsthand. If you've ever had a mammogram and it comes up positive, followed by an echocardiogram or an echogram, excuse me, yeah, that can cost a lot of cause a lot of emotional stress. There's a financial cost involved, especially if you don't have insurance to cover this. There's the medical resource cost. So if you're trying to get an appointment with your oncologist, that oncologist or somebody in X-ray might be busy testing people that might have false positives. Okay, so the possible consequence due to the follow-up test is also a bad thing. So let's say you have to go get a biopsy. That usually involves piercing the skin, and that could lead to an infection, which we don't like. Okay? All right, and then there's false negatives. The person has the condition or disease, but the screening test failed to identify the condition. All right, the person gets a false sense of security and okay, they don't think they need any treatment, so they forego any need for treatment. Okay, false positive versus false negative. So this is what we are trying to avoid with our tests, our sensitivity and specificity. Well, the sensitivity and specificity of our tests hopefully would eliminate this. But which is better? Do you want something highly sensitive or highly specific? Actually, if you have to choose, whoopsie, you want high sensitivity. That is the most important. You don't want to miss any cases that came up that might have come up false negative otherwise. So you want something with high sensitivity. If it's low sensitivity, you get you're going to miss a lot of people because they're going to come up as false negatives. Okay, they're going to, they're actually positive, but they're going to come up false. So you want highly specific or highly sensitive, excuse me. You want to catch everybody that you possibly can, even if you get a few false negatives in there. That's okay. Catch the disease in everyone and catch it early. Yes, they're going to have to go on and get some diagnostic tests. And yes, there are consequences to that, but it's better than dying of cancer. Just saying. Prevention is always better. Err on the side of caution, always. And yeah, you're going to get more false negatives, but that's okay. High specificity would also be pretty nice because then, yeah, if you could, you do want to reduce those false positives and the anxiety and the cost that does come with that, if you can, of course. Okay, but again, if you go with high specificity and you're not sensitive, well, you could miss some cases, especially in the early stages. So yeah, if it's only going after like a high concentration of some kind of marker and it's very, very specific, well, okay, yeah, but what if they just have a little bit of it? Okay, a question. A screening test with this result may have the consequence of causing a false sense of security and foregoing the need for treatment. This would be a true positive, a false positive, a false negative, or a true negative. Okay, that's going to be a false negative. You have a false sense of security and you don't get treated. This is not good. Okay, which type of screening test result may have the consequence of causing unnecessary anxiety, stress, and treatment? Okay, true positive, false positive, false negative, or true negative. Okay, false positive. But okay, it's better that they, are cautious. So this is better than going with false negatives, always. Okay? Okay, so which would you rather have? Make sure you know. Do you want specificity or do you want sensitivity? I would know that if I were you. Okay. All right. Now, you should know most positive tests from screening will be false positives. This is something you need to communicate to people in your family, in your community, and your patients. Okay. So, the risks of false positive screen test results. First of all, you should know the more tests that are ordered, well, the greater the risk of coming up with some false positive results in normal people. The more tests you put out there, the more false positives. That's just the way it is. Okay? And this, of course, is the tuberculin test. And if you have a lot of these out here and a lot of people getting a tuberculin test every single year, you're going to have a high rate of false positives. Okay? All right? And then you still have to go get an x-ray. And then they'll say, well, okay, we'll just kind of follow up on that. Okay. So again, if you do have false positive screen tests, there is that financial problem. Did you waste time and resources following up on a false positive test, especially with breast cancer? What are the chances of a woman actually having cancer after an abnormal mammogram, like me? So what are the chances? You were screened, you went in for your normal annual mammogram, and it came up positive, and then you did a follow-up diagnosis. What are those chances? Well, the chance does increase by age, as it turns out. Yippee skippy. Here is something from the New England Journal of Medicine, and this looks at a 10-year risk of false positive screening, mammograms, and clinical breast examinations. Okay? And they looked at, again, this was a 10-year study. It was a retrospective cohort study of breast cancer screening and diagnostic evaluation. And they looked at 2,400 women who were ages 40 to 69, okay, at the study entry. And they did mammograms or clinical breast examinations that were interpreted as intermediate, aroused a suspicion of cancer, or prompted recommendations for additional workup in women in whom breast cancer was not diagnosed within the next year were considered to be false positive tests. Okay, so of all of these women, okay, they had a test, a screen test. It looked positive, and then they went back for further diagnosis. And then these women were still looked at over a 10-year period. Okay? Okay. And mind you, these the young women to the older women, okay, that's something I'll come back to. But over 10 years, 1/3 of the women screened had abnormal test results requiring additional evaluation, even though no breast cancer was present. Techniques are needed to decrease false positive results while maintaining high sensitivity. Okay, so if we can't decrease false positive results, still go with high sensitivity. Okay, physicians should educate women about the risk of a false positive result of a screening test for breast cancer. So again, when a woman or if somebody comes up positive from a screening test, they need to know this doesn't mean they have the disease, okay? All right. By the way, if you look at this article, you will notice, however, the rate of actually having cancer increased as we looked at women in an older age group, right? That's why we always break things down by age. Okay, now, how about for the guys? Yeah, most positive screening tests tend to be false positives for the guys as well. Here's a good example, back to the prostate screening test. Now, remember I mentioned the prostate-specific antigen. This comes from blood. Okay, you can do a blood test and do that screening. And screening positive results are usually probably due to benign prostatic hyperplasia and not prostate cancer. But usually a repeat PSA is often combined with another blood test. The guys have to come back, and this is called a free to total PSA ratio, FYI. This test can sometimes help to decide if the high PSA in their bloodstream is due to prostate cancer or just benign or non-cancerous disease in the prostate. So elevated PSA levels, what can they mean? Well, yes, they can indicate prostate cancer, which is, or it could indicate a non-cancerous condition, like I said, like prostatitis, or just an enlarged prostate. Most men have PSA levels under 4 nanograms per mil, by the way, and this has traditionally been used as a cutoff for concern about the risk of prostate cancer. But this may lead to additional medical procedures, and men just love that, so do the families really, such as a prostate biopsy. But only about 25% of men with an elevated PSA level turn out to have prostate cancer after that follow-up biopsy, okay? So the rest of the time, again, it's probably due to some benign, swollen, enlarged prostate, that sort of thing. So, okay, what is the take-home message from this? This guy shouldn't bother to take this PSA test because they might get a false positive? No, the take-home message is to educate these gentlemen when they get a positive result that, okay, there's a very good chance this has nothing to do with cancer. Okay, so we just need to follow up on this. And again, even if all of these tests are a pain, some of the risks do outweigh the benefits in many screening programs, period. All right, how about some questions? Increasing the number of screen tests will blank the number of false positives. Increase or decrease? Of course, when you increase your number of screen tests, you're going to come up with an increase of false positives. That's going to happen. Takeaway message. Positive tests does not mean a person has the disease. Please pass this on. Thank you. All right, how about other qualities of good screen tests? So make it affordable. The EpiCh, by the way, is usually in some places like less than $10. It's pretty cheap. Make it acceptable to patients. Well, they're going to like this much better than having to go to the clinic and get their blood drawn, and yeah, okay. So you want it safe and convenient, if at all possible. Okay. All right, now what about patient characteristics for effective screening? Yeah, we do look at that. The patient should have a reasonable life expectancy if you're going to screen them for something. I mean, why would you order screening tests for a patient who is in their final stages of cancer? That doesn't make sense. Also, you need to make sure the patient is willing to undergo the follow-up test or tests. So if you know the patient would refuse any more tests, no matter what the outcome, then why give them the screen test to begin with, right? Yeah. So again, if they have advanced lung cancer, why schedule a patient for colonoscopy to look for colon cancer? That's ridiculous. All right. Prognosis. This is something everybody wants to know when they're diagnosed, don't they? So you get screened and you come up positive. You're like, okay. Come on, diagnostic test. Make me a negative. Make me a true negative. And no. Diagnostic tests say that you are indeed a true positive. Dang, what's your prognosis? Well, and this is also really, really scary and important for people who were diagnosed with cancer. And you should know no cancer is the same as another cancer. Even though there's a new cure for cancer almost every week, that is insane, okay? And in fact, even if you have two patients with the same type of cancer, they're going to be different as well, just so you know. So how do we define prognosis? So this is a prediction or forecast of the course of a disease based on anticipation from the usual natural history of the disease or peculiarities unique to the case. So anything really, really weird and unique to that particular case, okay? Okay, that's when we predict or forecast how that's going to happen. Now, there are prognostic indicators. Now, what is that? That tells the doctor the likely behavior of the cancer and its responsiveness to treatment. So here we have an example of bladder cancer, and you have different stages where it's very, very small. And then as it starts to grow and break through connective tissue and perhaps get into the lymphatic system, that sort of thing. And all this information is important and prognostic indicators for the doctor. Okay. Here's something, though, that the book mentioned, the International Prognostics Index, and this looks for survival rates. And this is, again, important for a lot of people with cancer. Now, who designed this, you asked? I'm glad you asked. Epidemiologists who are also oncologists, so people who, physicians who treat patients with cancer and who are also working in the field of epidemiology. Okay. And this is, for example, this is a tool to produce a prognosis for non-Hodgkin's lymphoma. If you haven't heard of that, I will talk about it just briefly. Hold on just a minute. And if this chart looks kind of, I don't know, like Miss Eden did this on her own spreadsheet Excel program, yes, that's what I did because I didn't want to use someone else's chart, but this is pretty much what the International Prognostics Index looks like. So you get a rating, a score, okay. So if you're greater than 60 years of age, okay, that gives you a number. And if you have impaired performance status, that gives you another number. If you're in stages of 3 to 4 of your cancer. Now, stages generally mean the later the stage, the farther it has progressed. It has gotten to different areas. Think of it in, if you've ever been in a stage production, stage left, stage right. So if it's going in different stages, it's spreading throughout the body. So that gives you another point. LDH elevated is a point. Extranodal, if it's inside the lymph node or not, I guess that doesn't give you a point. And so this gives you a total score. And the higher the number, the worse your prognosis is. So for non-Hodgkin's lymphoma, if that's what you have, a 0 to 1 rating means you're at low risk and your 5-year survival rate is 73%. More about that 5-year thing in just a little bit. If it's 2, you're low intermediate and your 5-year survival is about 51%. 3 is considered high intermediate, and your 5-year survival is only 43%, excuse me. And then if you're 4 to 5, that's very high risk, and your 5-year survival is only 26%. Now, mind you, this is only for non-Hodgkin's lymphoma, okay? I know we've talked about skin cancers and lung cancers and a lot of infectious diseases, but I wanted to spend just a moment to talk about these blood cancers, these blood diseases, known as Hodgkin's and non-Hodgkin's lymphomas. Okay, how are they similar? How are they different? Well, first of all, these are both blood cancers, and they arise from where your white blood cells are made in the bone marrow. Okay, and what they do is they attack the B cell white blood cell line. Okay, these are the white blood cells that make antibodies. Okay, so these are the ones being attacked, and you have way too many of these. Now, wouldn't that be good? You have all of these white blood soldiers circulating. No, no. You have too many of these white blood cells circulating, and it's all the same white blood cells. So you're probably going to be prone to a lot of infectious diseases. They can really mess up circulation. They can cause lesions in your bone. And a lot of times, platelet production is inhibited because of this. The symptoms are relatively similar between the two. So, but first of all, you have Hodgkin's lymphoma, and you should know that, okay, this is the more common one. The 5-year survival rate, depending on when it's diagnosed, depending on what stage it's in, okay, is about 67%. And I even hate throwing that number out there because it all depends on when this was caught, okay? It's all about that. It always is. Okay, and Hodgkin's lymphoma, this is much more rare. And the only way to tell the difference between these two really for a laboratory is to look under a microscope. Now, Hodgkin's lymphoma has these really weird B cells. They look like this. And if they're looking at your blood under the microscope and they see these Reed-Sternberg cells, they're giant, they're fused, they look weird, and they're multinucleated, they would say you have Hodgkin's lymphoma, and it's pretty common. Unfortunately, if your B lymphocytes look more like that, okay, chances are you have non-Hodgkin's lymphoma. Usually the symptoms are very similar between these two. You might have severe sweats. You might have fatigue, especially swelling in your lymph nodes. Little nodules may appear, and they would not hurt, and but they might spread to different areas, and then you'll feel more bumps, more little nodules, all swollen. Interestingly enough, I found this in my research. If you drink alcohol, they might hurt. Okay, so that is how so they have similar symptoms, but okay, non-Hodgkin's is more common. Hodgkin's is less common and has these really weird cells. But in addition to that, Hodgkin's most often strikes young people in their 20s, and then also older people, age 55 or older. Okay. Now, Hodgkin's disease, if you do get this diagnosis, yay, this is one of the most curable types of cancers. So that's some good news. 5-year survival rates, again, it depends on when you are diagnosed. But, and I probably shouldn't have that number in here, but the survival rate is considered to be 88% for 5 years. Okay, we'll talk about survival rates a little bit later on. Okay, about survival. When people do get a diagnosis in their prognosis, they want to know survival time, or they want to know how long they're going to live. So we're going to look at 2 indicators of that. First of all, there's the survival time, and then there's survival or cure rate. But survival time is just that. So what this does, epidemiologists look at a group of patients with this diagnosis, and they take an average. So this is the average or mean survival time of the group of patients. And I have a graph just showing, actually this shows the median, but it's usually measured in days. They're looking at the typical number, really. Does this not mean that there might be somebody who lives longer or shorter? Oh, no, there are clearly going to be outliers, okay? People who do live have a longer survival time or a shorter survival time. But this is just taking an average, okay? All right, and then there's a survival rate, because this is a rate, this is a percentage number, not just a number of days, okay, or mean survival, okay? Survival rate is the proportion of persons surviving after diagnosis or treatment. Now, you should know, however, that survival rate really doesn't tell you that they died from that disease they were just diagnosed from. They could die from pneumonia, but they were diagnosed with cancer, right? So survival rates are not the most accurate, unfortunately, but it does give us a number. And again, the survival rate is regardless of the actual cause of death. I know. So you have to take these numbers with a grain of salt. So usually when we talk about survival rates, also sometimes referred to as cure rates, that makes me cringe a little bit because I study virology, but usually they talk about 5-year survival, especially with cancers. And we were talking about Hodgkin's and non-Hodgkin's lymphoma and their 5-year survival rate. So let's address that. So again, it's looking at the number of people who would be cured after surviving 5 years, okay? So, however, some cancers are much slower, and that 5-year survival rate or cure rate really is not going to reflect those cancers. So, for example, if you have liver cancer or breast cancer, some of those cancers, not all, are very slow. And okay, you can get all the, you can get all the treatments and interventions, but it can come back in about 10 years because it's so slow. So really for these types of breast cancers and liver cancers, maybe a 10-year survival rate or cure rate is a better indicator, okay, of survival. But again, it doesn't mean for sure they died of that cancer. And then some cancers are really, really fast. If you have, for example, pancreatic cancer, all right, if you make it 2 years past diagnosis, okay, we'll give you that, and we'll say that's your cure rate time for that. So maybe a 2-year survival rate or cure rate is a better indicator, okay, and best reflects a cure. And this is just showing 10-year survival rates by tumor types. And this is just showing 1971 versus 2011. So you do that and you can make some nice graphs, okay? And this is from Pancreatic Cancer Action. So it's kind of interesting. All right, so how about measures of prognosis, meaning let's do some calculations, and it's okay. All right, so first of all, let's calculate case fatality rate. Well, again, it's a rate, so this is a proportion, meaning we're going to get a fraction, and then we have to multiply by 100 to get a percentage rate, right? So a case fatality rate, what is that? That's the proportion of newly diagnosed cases that die from a given disease in a specified period. Okay, so how do we calculate that? So we look at the number of deaths from a specific disease, like cholera. I found these numbers very quickly. So the number of deaths from a specific disease over a period of time. So deaths due to cholera during 1998. Okay. Divided by the number of individuals diagnosed with the disease during that time. So over the total number of cholera cases in 1998. Okay, so the deaths over the number of total cholera cases. So you're going to get a fraction, right? So some kind of ratio, but you must multiply that by 100 to get yourself a percentage times 100. Okay, it's not that hard. If you ever have to come back and calculate this or look to see what case fatality rate looks like, just look at your notes, okay? All right. And of course, once you do those lovely, lovely calculations, you can do a beautiful graph like this. And of course, this allows people to be able to compare fatality rates due to cholera in this case. So, and you can see in Africa, you get the lighter colors, Africa, America, and Asia. And it shows the case fatality rates. And 1992 was a bad year. Okay, so how about some questions? What is the measure of survival analysis? That is the average survival time for a group of patients. So is that survival time, survival rate, case fatality rate, or predictive value? What do you think? Okay, it's an average. Okay, so it's a time. Okay, so we're talking about an average. So we're looking at survival time. Okay? Okay. A problem with case fatality rates is that it is difficult to associate the death with the diagnosis. Is that true or false? Yeah, that's true. The case fatality rate just says you died after diagnosis. It doesn't say that you died because of that disease that you were diagnosed for. I know, messed up, huh? Okay. The 5-year survival rate for colorectal cancer is 63%. What am I describing? A cure rate, a survival rate, a prognosis, survival time, or case fatality rate? And this is tricky. Could there be more than one? Yes, by golly. Actually, the first three, cure rate, survival rate, and prognosis, all would be correct. Yay. Okay. The number of deaths due to breast cancer in 2011 was 39,520 women. The total number of cases of female breast cancer was 3,418,124. I know, wow. What calculation would best produce a useful epidemiologic number measuring prognosis? Cure rate, survival rate, prognosis, survival time, case fatality rate. What do you think? Okay, well, it's got to be a rate, right? And we're looking at case fatality rate because we're looking at the number of deaths due to breast cancer, right? Right. When it comes to epidemiologists providing all of this information to physicians and their patients about a prognosis, many study designs are used. And here, of course, we have our epidemiologic studies, so this should look familiar. Descriptive studies cannot study relationships, so they're not going to give you the best prognosis information. Analytic studies will, actually, because they do study relationships. If at all possible, you'd probably want to do a cohort study and follow groups in each stage of a prognostic factor and follow them for a period of time. So again, stage 1, 2, 3, and 4, and usually, of course, with cancers, you would the study would be set up at about 5 years. Randomized case controlled randomized case controlled trials are also sometimes used. Case controls are not as valuable. Usually, again, epidemiologists sort of favor the cohort studies. Okay. Let's go into bias. Oh yes, this is important when you're trying to figure out if a screening program is useful, if intervention is useful after a diagnosis, if you're trying to figure out if what a prognosis is, you need to look up bias. This is all important. Now, there's several different kinds, and I will go into them now. There's, first of all, lead time bias. So, just a little reminder before we go into this. So here's the course of disease from biological onset, okay, a few cancerous cells, to clinical diagnosis, meaning, okay, you would have felt the bumps and you would have gone in for a clinical diagnosis, okay, because you're starting to have symptoms. And then you have your outcome, good or bad. Okay, and again, screening should occur from the onset, okay, to clinical diagnosis. And if you want to evaluate how well a test is, okay, this is what you're going to look at, okay? All right, so first of all, we're going to look at what lead time is. Lead time is the time between screen test detection and symptom development when you would have had a diagnosis anyway. Okay, so lead time is basically the difference between, okay, finding out through a screen test up to when you would have gone in because you have symptoms. So this is considered a lead time. Now, there's a lead time bias that is sometimes found in epidemiologic studies. Okay, so we're going to compare lead times between unscreened patients, and screened patients. Okay, so in an unscreened patient, okay, if they never got the screening, if you start counting years of survival from the date of diagnosis, okay, and intervention, the survival time is short, right? That makes sense. The survival time is pretty short. Okay, that's unscreened. Now, in a screened patient, that means that you're going to start counting years of survival earlier than, okay, unscreened patient started here. So you had a very short years of survival, okay? But with screening, that looks like, oh, okay, so they're diagnosed way back here because of screening. This looks like their survival time is longer, but that's not necessarily so. So yes, doing screen tests make the survival rate look longer, and it may even appear that treatment is, is working or something. But this does make survival time appear long, even if treatment is ineffective, and this leads to lead time bias. And it can make early treatment seem effective when it is not. It just means that, okay, they spent more time knowing they had cancer. Okay, that's all. So lead time, the difference in time between the date of diagnosis with screening and the date of diagnosis without screening. Lead time bias is when the lead time is counted in the survival time of patients. It gives a misleading picture of the benefit of treatment. Again, it just means that, okay, if you screen, sometimes that just makes the patient, or if you screen, the patient just knows they have cancer earlier. It really does not extend their survival rate. Okay, this is what can happen with lead time bias. How about a question? When the difference between the diagnosis date with screening and diagnosis date without screening is counted in the patient's survival time, this may result in A, lead time bias, B, length bias, C, selection bias, or D, overdiagnosis bias. So when the difference between the diagnosis date with screening and the diagnosis date without screening is counted in that patient's survival time. That's lead time bias, you bet. This bias will make an intervention or treatment appear to extend patient survival, even if the intervention or treatment has no effect. Lead time bias, length bias, selection bias, or overdiagnosis bias. Yeah, still, lead time bias, A. All right, let's talk about length time bias. We haven't done that yet. All right, so here's our little chart here. And oh, do you remember the sink? So we must be talking about incidence or prevalence and or both. Okay, so here we are. And again, this is that asymptomatic time for screen detection. Here it's too late because you've already got symptoms, so screening wouldn't help this person. Okay, so screening picks up prevalent cases. Okay, if it's really, really common, screening is going to pick it up. And screening, as far as the prevalence, that's going to be incidence times duration. But here's the thing. It can depend on the progression of the disease. For example, slowly growing tumors have a greater duration in the pre-symptomatic phase. So they have a very long pre-symptomatic or asymptomatic phase. Very, very long. Okay? And therefore, it will be identified by screening more often because it's out there. Chances are in this long period of time, this woman's going to go in and be detected by screening. Okay? But slow growing tumors therefore look as if it makes it look like there's a greater prevalence in the population. Okay? And slow-growing tumors appear then to have longer survival, independent of treatment, by the way. Okay. Now, let's compare. Aggressive tumors. This means a very short progression, short lifespan, probably. Okay. And aggressive tumors have a very short asymptomatic or pre-symptomatic clinical phase. Okay. So there's a good chance this won't be caused by screening, right? So aggressive tumors have a short asymptomatic clinical phase, so it might look like it's not prevalent in the population, and this is length time bias. So there's an overestimation of survival among screen detected cases. So it's like, oh yeah, okay, if you're getting screened, we can say you're going to live longer. No, it depends on whether or not it's slow or fast growing. There's also something called overdiagnosis bias. So this occurs when screening identifies an illness that would not have shown clinical signs before a person's death from other causes. So, okay, they're very, very ill, but hey, we found you have colorectal cancer. It makes screening efforts look good because of increased identification of abnormalities. The individual, sadly, may undergo unnecessary treatment with all of its accompanying risk. Okay, and which, sadly, it's an overestimate of how well the screening test works. So, overdiagnosis bias. Finally, I'm going to mention something about publication bias. This is something you have to be aware of. You really do. And this also has an assignment linked with it. You're going to be watching a TED Talks video. But this directly ties in with clinical medicine. And yes, something called publication bias. So what are these big journal publication companies? What are they? Are they publishing all the information that we need to make decisions, clinical decisions? Are they? One would hope. And here I laugh at this because this definitely shows bias in research. Let's say one of your findings in some of your data just didn't look nice, or it showed an unfavorable result and you need to get published. Because if you can't publish, you perish. So you just kind of get rid of the data and the information you don't want. It's unfavorable, it's ugly. Because yeah, we want pretty data. And we want something that'll get published in the main journals, right? Because main journals, they tend to want to only publish favorable information. They don't want to publish a study you did that said, well, this drug doesn't work. Yeah. So publication bias is the tendency to submit or accept studies for publication based on favorable results. Withholding negative results from publication could impact the health of millions. If unfavorable or negative studies are not published, then there is a bias estimate of an outcome. Okay? It distorts the data and leads to misguided research and teaching practices and therapeutic options, don't you think? Positive studies do tend to get published much more often than negative studies, and unfortunately, that has been proven over and over again. Oh, this drug works according to the data and the studies that I've cherry-picked, so I will submit that only, and oh yeah, it gets published. Okay. If this drug is worthless, well, then nobody wants to publish that. There are many types of reporting and publication bias, which I won't go into. So should a study be published or not? Lots of things do go into publishing, and it is, there is a lot that does go into it, and these companies have to make a profit, and there usually is a board of peers that evaluate submissions. But I have a friend who has worked at NIH, and they will tell you that sometimes big research lab investigators will submit garbage, and that tends to be looked at more so than the little publications and the little bitty laboratory experiments from little labs that are just starting out. There's just a lot. Now, here's a personal example of research and publication bias, where only favorable information would be published, and if it wasn't favorable, it did not get published. So this is my first encounter with this, and I was just starting out in research, and I was working in infectious diseases, right, with Neisseria gonorrhea. No, this isn't me, but Male pattern baldness. This is a big industry out there. And now to get treated for male pattern baldness at the time, there was a drug and you had to get a prescription for it, but it was known as Rogaine. This is Rogaine for women, by the way. And at the time, yes, you needed a prescription. Okay. And researchers, well, and investigations indicated that only certain people responded to Rogaine, and that's still true. So they were trying to figure out exactly what was it about people's chemistry that made them respond to Rogaine or not respond to Rogaine. Okay, now I was just starting out. I had student loans, yikes, and they needed control scalp samples. So I volunteered because it was $100, and that was enough for me to say, yeah, punch a hole in my scalp. I have enough hair up there right now, so we're okay. But they would use an instrument like this. This is a biopsy punch. It is a sharp ended hollow tube, and you punch it into the tissue like a cookie cutter, and when you pull it back up again, it pulls out a plug of tissue. And in that tissue, they were trying to find a particular enzyme called sulfotransferase. Here is what they suspected. Only people who had enough sulfotransferase would respond to the drug, the main active ingredients in Rogaine, called minoxidil. So they were trying to see, okay, in my scalp, did I have enough sulfotransferase, okay? And again, this was designed ultimately to decide who would benefit from Rogaine and who would not. As it turns out, before these research studies came out, which I thought was rather cool, Rogaine went over the counter. What does that mean? That means that, the last thing they wanted was information out there stating that certain people would respond to Rogaine and other people would still continue losing their hair. So, yeah, once it went over the counter, the results were not published, which was too bad. Lots of really good research was in there. And there might be something else tied in with sulfotransferase, okay? But nope, that just, and this was funded by the drug company. Yes, it was. All right. And granted, this is probably not going to have a huge medical impact, but it might. It might. Let's say that you want to know if a certain diagnostic test is accurate, or a certain treatment or intervention is accurate, or a drug works. Well, you could look at something called a systematic review. This means that somebody went out there and looked at many, many, many trials, many studies, and they plotted them in a structure that looks like this. This is a funnel plot. Now, if you are a drug company, you're probably not going to get FDA approval based on one study. You're going to have to do many studies, and you're going to have to do then a systematic review and have a nice little funnel plot. Okay, so this should look at all the studies done on that treatment or intervention or test or diagnostic test, whatever. And it should show if negative trials are there or if they're missing. So in other words, if the drug didn't work or the test didn't work, it should show up on this funnel plot. Now, each dot represents a trial. The higher peak, shows the bigger trials, and they're up here because, there's more people. That means less error and less false positives and false negatives too. The bigger the trial, the bigger the number of test subjects, and so those are going to be pretty big up there. The left side are where the false negatives are. So that would be, all right, it showed, so remember with false negatives, that means that it's not working. The drug is not working, or the test is not working. The right side are false positives. Okay. So what if there are small negative trials missing in action? What would you see then? So if the negative trial is saying that this didn't work, where would you see that on a funnel plot? Okay, well, then you would see something skewed. So here's our peak, and we're seeing over here the false positives, but we're not seeing the false negatives. And here they were doing odds ratios, by the way, just so you know. So yeah, this would be a red flag. And this is publication bias in a systematic review. So if you don't have this, this is not good. All right, how about a question? Which funnel plot shows a lack of false negatives, also indicating probable publication bias? A or B? Yeah, of course, A. This one looks pretty darn good. Actually, this is telling you that you're getting a lot of false negatives there, so that's pretty good. All right, now, there is a video I want you to watch on TED Talks. And this is it's called What Doctors Don't Know About the Drugs They Prescribe. This is presented by British physician and epidemiologist Ben Goldacre. He is quite the character. I've read a couple of books of his, and he's quite passionate. He talks fast. So you're going to have to listen very carefully. Why? Is there a quiz? No, there's no quiz per se over this this week. However, I will include some questions about this TED Talk in the 4th exam. Now, in addition to watching and taking notes, you also will want to print up or have the worksheet, and I will have that provided with the link to the TED Talk, okay? So that will be there, and it will go through, and it will ask you questions. It will take a little time, but as I said, this lecture is not taking very long. This is a very, very important lesson to learn, and this is why I'm spending so much time on publication bias, in spite of the fact that your author just barely talked about it, you know, and really kind of glanced over it. Finally, so avoiding bias, randomized controlled trials always avoid bias. And through randomization, different prognostic factors are balanced between groups, and the true screening or treatment effect can then be determined. So randomized controlled trial studies, always the best. One final thing in the lecture is, and this is something your author did include, which I like very much, this is outcomes research, and this is a relatively new field that seeks to understand the end results of clinical practices and interventions. So, you know, it follows all of these interventions and screen tests and diagnostic tests. So it measures the quality of care, which is awesome. And it combines information about the care people are getting. And it's important in developing better ways to monitor and improve clinical care, which is really ultimately what we would like to do, or one of the main things we would like to do. All right, some take-home messages. Back to this. Every week, all right, you hear about one study that shows that wine, you know, is going to protect against cancer, or wine causes cancer, tomatoes protects against cancer, causes cancer. There's always, especially coffee. This one really irritates me because don't mess with coffee, okay? But yeah, this information gets out there, and it's not that there's bad scientists out there, but boy, our reporting methods are bad. And the take-home message is, in the future, when you look at these studies or hear about studies, don't go by one medical study to make up your mind. Use what you have learned in this class to critically evaluate the validity of a study or a group of studies. You know, search for many studies that are well designed, unbiased, and transparent. Okay? All right. In conclusion, clinical epidemiology involves the application of epidemiologic methods to improve the quality and value of patient care. It involves assessment of the efficacy of screening, diagnosis, and treatment strategies in clinical settings. Boom! Okay, well, you know what? we are done with the book and almost done with the class. However, okay, don't forget that, all right, so you have to listen to the TED Talk and take notes because that might come up in chapter 4, or excuse me, in the 4th exam. Don't forget you still have a discussion assignment also due this week. And I'm combining everything this week so you can get it done so that next week all you have are 2 things to worry about. Your last exam and working on that video because it's worth a lot of points. And remember, everybody is going to be looking at that video, so you want to up your production value. Yes? And of course, if you have any questions, if you need any help, please, please, please do not hesitate to let me know. I'll be delighted to help. And you have a really great week. Bye-bye.